Okay, just a little bit about us. We are a global initiative for expert manual therapists. We started this because we found that there is a huge gap between people who have basic education and people who are fellowship trained in the US, and people who are who are fellowship trained, which is myself and Dr. Steve. We are exposed to a lot of recent research, exposed to a lot of skills which are not taught in the basic education. So the idea behind this was to start a program which mimics a fellowship program in the US. And we have a program running currently in India. We just started our cohort 2 back in December. And the program is 1 year. We come to India twice a year for two hands-on sessions, and we meet one weekend a month, which is 8 hours, to discuss a certain topic, a certain module, and talk what is the recent research about it, what is the trend about it. Okay. And yeah, I think we're planning to come again in March and April timeframe. And the two cities we have selected this time around is Delhi and Bombay. And we plan to come to Southern India at some point. Uh, Without talking too much, I think I'm going to give time to Prashant to talk about. Prashant is a seasoned therapist. He owns his own practice in Aurangabad. He's been practicing for almost a decade. Yeah. He's gone through our certificate in evidence-based practice or evidence-based orthopedic manual therapy program. He's certified in dry needling. He's a seasoned guy, has done his certification in rehab trainer, has been doing this for a long time. And the thing is, it doesn't matter how long you've been practicing, you have these research trends you see, and which makes you think that, am I practicing right, or can I need to modify something? So, and I think that's it from my side. I think over to you, Prashant. I mean, yeah, I think teach us something. I think this is an important, interesting topic.
Yeah. Thank you very much, sir. Good morning, everyone. Good evening. If suppose somebody is from the outside India, now our topic is most common first diagnosis of piriformis syndrome. So there are many, my students are also there in the PPT and in this lecture. So we are practicing since few are practicing since many years, few are just interns and all. So we are seeing most of the cases we are saying piriformis syndrome. So most commonly as we are saying it is a piriformis syndrome, but most of the times it is a false diagnosis. So in this PPT we are going to see the contents would be like hip and pelvis anatomy. After that we are going to see the biomechanics and arthrokinematics. After that we are going to cover common causes of posterior hip pain, what are the special tests for that, and most important part which we have covered the research and literature. On the basis of that we have made this PPT, and later on we are going to discuss a interesting case study which will help us to know how the diagnosis should be done, or what we are missing as a physio, and what physician or orthopedicians are also missing. So this is a very interesting case study, and later on the important part, treatment and exercises would be there. Yeah. Now we'll start with the hip anatomy. So hip joint is composed of acetabulum and the femur, the head of the femur. So if we see, the acetabulum is a part of the pelvic bone, which is made up of the ilium, ischium, and pubis bones. So which is going to the attach to your pelvis bone. So it is the diaphragmal joint, which is the synovial joint, which has a 3 degree of freedom. So this is the composed of main acetabulum and the femur bone. Next, Dhruvi. So if you see the image, the femur bone is, the head of the femur is attached to the acetabulum socket cavity, and later on, next. Dhruvi. Yeah. So ligaments of the hip joint. So any joint is supported by the ligaments and the muscles. So ligaments plays an important role. important role while the stabilizing the joint. So anteriorly it has been supported by the iliofemoral and pubofemoral ligaments, where posteriorly it is supported by the ischiofemoral ligament. It will help to stabilize the joint by just preventing the excessive translation of the bones, and it will help us to make it happen the normal range of motions. So these are the images. These are the images of the ligaments, where iliofemoral ligaments are. Am I audible to you all?
Yeah, you're good. You're good, Prashant. Yeah, these are the ligaments around the hip and
Yeah,
pelvis.
yeah. These are the ligaments around the hips and pelvis. So anteriorly, we are seeing the iliofemoral ligament is there, and the pubofemoral ligament there, and posteriorly it is supported by the ischiofemoral ligament. Next, Rumi. Next. Now we are going to see the muscles of the hip joint. So muscle of the anterior compartment, as we are seeing in the images, the tensor fasciae lata, sartorius, and the quadriceps femoris, which consists of the four muscles. So this is the elementary education, or this we have seen in our first year of the college. But just to revise everything, I am just letting you know. So quadriceps femoris is just made up of four muscles, which includes rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, and articularis genu. Now we'll see the medial compartment. So in medial compartment, we have the adductor, where we can see the adductor longus, magnus brevis, and ischial head of adductor magnus, and gracilis muscle, which will help us to adduction of the hip joint. Now we'll go to the posterior compartment of the hip, which will which will help us in extension of the hip, where gluteus maximus is the major largest group is present around the ilium, where all the hamstrings are covering the posterior part of your thigh, which contains of semitendinosus, semimembranosus, and biceps femoris. Next. Now, today's topic is the false diagnosis of piriformis syndrome. So we are going to see the posterior part, the deeper muscle of the hip joint. So if we can see, there are piriformis, gemelli, supergemelli, inferior gemelli, obturator internus, obturator externus, and quadratus femoris are present at the back of the hip. But if we see, according to the research, there are close proximity between the piriformis tendon, obturator internus, and gemellus inferior. So whenever if you see any problems around the piriformis muscle, so research study shows that there will be the involvement of obturator internus with the inferior gemellus. So when you have the hip pain, if you are saying the uh, piriformis is going to hamper the function. So not only the piriformis, there are the chances of superior gemelli, obturator internus, and gemella inferior in the hip joint. Next.
Okay, I think so. The point is that we call it piriformis syndrome, but we look at the literature, we look at ultrasound studies, we see the problem is just not in piriformis. Problem is in these two muscles as well, inferior gemelli and obturator internus, whenever there is an issue with piriformis. So should we call it a piriformis syndrome? Just think about it.
So these are the muscles with the movements. The flexion is caused by the psoas major, iliacus, rectus femoris, sartorius, pectineus, where extension is caused by gluteus max and hamstring muscles, where abduction is caused by gluteus maximus, minimus, medimus, and the tensor fasciae lata, where adduction is caused by adductor mangus, longus, brevis, gracilis, and internal rotators are gluteus medius, minimus, TFL, and the iliacus, where external rotators are gluteus maximus, piriformis, obturator internus, superior inferior gemelli, and quadratus femoris. So now, after the anatomy, we are going to see the biomechanics. So what is the need of the biomechanics? As a physio, we have been treating the muscles till now, because before joining the gym class, I was also doing the TENS and ultrasound, all those things I used to do. But after completing the course from the gym, I came to know biomechanics is also important, where we are not focusing on the bones. So the bone movements are also necessary for the diagnosis, assessment, and the treatment purpose. So because of that, we have added the biomechanics. So in biomechanics, we are going to see the osteokinematics and arthrokinematics. So what is that osteokinematics? Osteokinematics means like there is the bony livers, all the bones are present there. What are the what is the movements are happening in the bony liver in the space when the physiological joint motions are happening? Where arthrokinematics is what while doing the bony movements, what the surface which is happening between the joint, what kind of motions are happening in the joints. For example, if I'm doing the hip flexion, so hip flexion is the osteokinematics. But what is the arthrokinematics for the hip flexion? So while doing the hip flexion, there is a spinning and anterior posterior movement are happening at the acetabulum and the head of the femur. So the spinning movements which is happening at the anterior posterior direction while doing hip flexion and extension is the arthrokinematics, where the action which I was doing flexion, that was the osteokinematics.
Uh,
Now with the movements with flexion extension, will will cover the what is the arthromatics happening. As I have explained, while doing the flexion and extension, there are the spinning movements are occurring at the femoral joint in the acetabulum cavity. So there will be the anterior and posterior glide with the spinning movement happens when we do the hip flexion and extension. While in abduction, there will be the inferior glide will be happen at the femur. When we do the hip abduction, so we can see there is the inferior glides are happening because the head of the femur is moving in inferior direction while we are doing the abduction. So while doing the adduction, this is the adduction. So the head of the femur will go in superior direction. Where in internal and external rotation, this is the internal rotation, this is the external rotation. So in external rotation, femoral head goes posteriorly, head goes posteriorly, while doing the external rotation, femoral goes anteriorly. So this is the important part where we have to see while doing the assessment, what is the hip arthrokinematics are happening while the range of motions. Next. So these are the images where osteokinematics and arthrokinematics are has been shown. When the first image is of hip flexion, second is in abduction and adduction, third one is the medial rotation of the hip, and fourth one is the lateral rotation of the hip. Next. Now we are going to see we have gone through the hip range of motions, hip arthrokinematics and biomechanics. Now we are going to see the motions are happening at the pelvis on the femur. So whenever the hip joint is weight bearing, so when we are standing, so at that time we get the motion at the pelvis. So my hip joint is weight bearing. Now I am standing on my both the legs. Now I am moving. So my hip joint is fixed, and at that time the motion is happening at the pelvis. See, I am doing the flexion, so my hip joint is fixed. So the action is happening at my pelvis. When I am doing extension, the action is happening at my pelvis. So the biomechanics is there. Ruby, can you go to the next slide? The images for the side. Yeah. So if you can see the images, there are two horizontal lines has been drawn on the both the ASIS level and PSIS level. When your pelvis is aligned, so it has to be at the same level. Both the horizontal line has to be at the same level. But when you do the flexion, see, when you do the flexion, so while doing the hip flexion, there will be the anterior tilting of the pelvis will happen. You can imagine the things. So because of that, I have put the images on. So while doing the flexion, please review the second image. While doing the hip flexion, there will be the anterior tilting of the pelvis is happening. So see, I am doing the flexion, so automatically I am going slightly ahead. So anterior pelvic tilting is happening, where the sacral base and the sacrum is moving posteriorly. It is going the away from the body. And while doing extension, posterior pelvic tilting is happening, where sacrum is going into the close proximities of the hip joint. So we need to know the how the joints are moving while assessing the joints or while assessing the any diagnosis. Next. इसका आ जाओ, lateral pelvic tilt. Yeah. Should I continue, sir?
Yes, yes.
Yeah. Now we are going to see the lateral pelvic tilt. So as we know the pendulum back sign, if you have the less power at the gluteus medius muscle, then you will find the lateral pelvic tilt. Yeah, sorry, I was reading the comment. Yeah, so you will find the lateral pelvic tilt. But if you see when the muscle, it is so lateral pelvic tilt is in frontal plane of the axis, which happens around the anteroposterior axis. So what is the function of the gluteus medius? It holds the opposite side of pelvis at the neutral position. But if we found the gluteus medius power is less than 3 or 3, so the opposite side pelvis will drop. So the reason behind is this: if you find any sacroiliac dysfunction, so there will be the neurophysiological insufficiency happens at gluteus medius, or because of that there will be shutting down the shutting down of gluteus medius happens, and because of that is unable to hold the pelvis at the positions. So the holding of the pelvis will be counteracted by the TFL, so that there will be the hypertonicity or hyperactivity of TFL happens. So there is the reason why all the patients get the TFL tightness.
That's a very important point. So if you have like gluteus medius weakness, TFL will substitute for the weak glute med, and your obers could be positive.
Next, Bhumi. Now we are going to see the common causes of posterior hip pain. Next, Bhumi. So first cause we are going to see, we are going to see one law, Hilton's law. The law says that the joint is supplied by the branches from the nerves supplying muscles acting on it. What does this mean? This means if a particular nerve is there which is supplying to that joint, and that is supplying the muscles also around that joint and the ligament around that joint, so whenever that nerve gets interrupted, the function of that nerve get interrupted, so there will be the problems happen at that same joint. So according to that, based on that Hilton's law, so if you get the referred pain in your hip, so it might be you will get the back pain, because the hip muscle is mostly supplied by the L3 nerve roots. So if you find any difficulty in L3 nerve root, or if you find any damage or any derangements at the L3 joint, so you can find the same referral pain in your hip, because the hip muscles are supplied by the L3 nerve. So this is the Hilton's law. You should remember the nerve which is supplying to that joint and muscles can refer pain to the muscles which it is supplying. Next. the point which I have covered, the hip receives the innervation from the branches of lumbosacral plexus from L to the S1 and predominantly from the L3 inner root. So if you find any problems in L3 inner root, the pain you might get the pain on your posterior hip joint.
Sorry to interrupt, Dr. Prashant. Can you repeat Hilton's law one more time? Like, I think it is a little complex.
Yeah, I'll tell you in another. I'm not going to state the same sentence like that. The joint is supplied by the branches from the nerve supplying muscles acting on it. For example, if you consider the uh, uh, knee joint, so the knee joint is supplied by the obturator nerve. So for that, the muscles are supplied by the obturator nerve. The muscles are supplied by the obturator nerve, which are also supplying the knee joint. So if you find any difficulty or any problem in obturator nerve, so it's going to hamper the function of obturator nerve. The muscles are supplying to the obturator nerve plus the knee joint. Am I clear to everyone?
Yeah, yeah.
Sorry. Now the second cause of posterior hip pain is inflammation of bursa. So there are the number of bursae around the hip joint. So posteriorly we can see the iliopsoas bursa, ischial tuberosity bursa, and trochanteric bursitis. Now, but according to the research, one researchers have said there is no such terminology like bursitis and all. So they have just classified it as greater trochanter pain syndrome. So Dr. Hassan has been taken this lecture about this. That was a great lecture. So you can refer that lecture about the greater tubercle pain syndrome.
Dr. Hassan did this lecture like on GTPS. It's called Greater Trochanteric Pain Syndrome. It's available on YouTube if you guys want to watch it.
So if your pain is going down the leg or it is going down the knee from the back, so you can follow the dermatomes. So for that, I have added this image. Now we are going to see the piriformis syndrome. As we know, piriformis is the major muscle which is acting while external rotation of the hip. So if you see the origin of the muscle, it will this is the anterior part of your sacrum. So is it okay? Yeah. So if we see, this is the anterior part of your sacrum. So it starts from second, third, and fourth digitation, and from the greater sciatic notch, it runs towards the medial head of the greater trochanter. So see the origin of the piriformis muscle. This is like this. This is a fan shape kind of a structure which is present around the sacrum, which is going to insert on the medial trochanter. The action of piriformis is when hip is extended, it acts as an external rotator, and when the hip is at 90 degree, it will act as the abductor. So which will be which we will explain in pace test, which will be on the next slide. I will explain what is the pace test. And the nerve supplied by S1, S2 is supplied to the piriformis muscle. Wait. If you see the images, if you see the images, see from where the muscles is coming and where is it's inserting. So while considering the piriformis muscle, when you stretch the muscle or contract the muscle, you get the pain. So this is the important point. What kind of nerve supply it is? What nerves are around the piriformis muscle? What is the blood supply to it is? So there is blood supply superior and inferior gluteal nerve, and in pudendal nerve it supplies pudendal artery. It supplies to the piriformis muscle. Next. So we'll go little bit detailing about the piriformis syndrome. So Ehrman is the person who speculated about the piriformis muscle with the sacroiliac joint osteoarthritis in 1928. So since 1928, there has been there has been lot of research has been done on the piriformis muscle, and the piriformis syndrome was coined by the Robinson in 1947. So he has described a form of sciatica with the abnormalities in piriformis muscle. So he has introduced the piriformis and sciatica correlation as a piriformis syndrome in 1947. So if you see, the piriformis syndrome was defined as a buttock pain or sciatica, which is caused by the impingement of the sciatic nerve. So earlier it used to be diagnosed by the MRI endoscopic visualization. So we need to see the what are the symptoms we are getting after stretching and the contraction of the muscle. So on the basis of that, we are going to do the assessment of the piriformis muscle. Next. So epidemiology of piriformis syndrome. So globally, there are 40 million cases has been found annually, where out of that 6% are of piriformis syndrome. And average age group of piriformis syndrome, which is found in the people are 38 years old, where females are more prone to piriformis syndrome as compared to male. The ratio is 6:1.
So more common in females than males.
Now, one image is there in front of you of sciatic variation. Now we'll do a little bit of interaction. So there are 6 images. So can you put the in chat box which of the images, means which of the anatomical variations you are seeing? That red part is piriformis, and that white part are sciatic nerve. So which image is going to give you the symptoms below your knee, like tingling sensation, burning sensation, or down leg symptoms? So will you please put the number of images like A, B, C, D, E, F in the chat box? Which image is going to give the symptoms down leg to the person?
This 2, 4. I mean, you're kind of right. So you see those two. I just want to clarify this. You see the muscle and you see the nerve, right?
Yeah.
You have to tell us which patient presentation or which sciatic variation will have symptoms down the leg. The answer is more than one. Okay. The two branches you're seeing is common peroneal nerve and tibial nerve. The top branch is common peroneal, the lower branch is tibial. We know that those are the two branches, right? So you have to tell us which will give you. The answer is just not one. You have multiple. You have to choose multiple options. So look at each picture, and then give us the right answer. So you said B, C, E. If you look at C, the nerve passes above and below. Are you guys getting the point? The red strip is piriformis muscle. The yellow is the nerve. All except 6. I think you guys have to pay attention to this. I think we'll do. One of you actually got it right. One of you got it right. Dr. Prashant, you can give the right answer.
Yeah. Yeah. Thank you for the answer, guys. Now the answer is B, D, and E. So why is the B, D, and E? If you see the first image A, the sciatic nerve is traveling from the below the lower border of the piriformis. So there will be no impingement happens at sciatic nerve. So that has been ruled out. Second, if you see the second image, where we got the 13% of the patients in this case anatomical variation. The muscles are traveling. One branch is traveling from the middle of the muscle belly, and another branch is traveling from the below the muscle. So the upper branch is peroneal nerve, where the lower branch is tibial nerve. So there are the chances of impingement of the nerve, where we can get the symptoms down the leg. So B is the first answer. Now you can see, now you will get the answer. Now you can see the C. One muscle is coming from up, one muscle is coming from down. So there will be no impingement. So C is not the answer. Now you can refer the D, where the nerve is coming from the middle of the belly without any bifurcation. So if any contraction or stretching or any injury happen to the piriformis muscle, so it will impinge the sciatic nerve. So they will also give the symptoms to down to the leg. Now, if you see the E, one is coming from the superior border of the piriformis, and another is coming from the middle of the belly. So you will also give us the symptoms, where F, where the muscle is coming from the superior border of the piriformis muscle.
Yeah.
So now you can tell the answer.
So the answer is B, D, and E. Do you guys understand this? So you're seeing the red strip. That is your piriformis muscle. The yellow is your nerve. The bifurcation you see, the top branch is your common peroneal. The lower branch is your tibial. So it doesn't, if common peroneal, tibial, or sciatic, one of the branches or the whole nerve passes through the muscle, you're going to have symptoms of numbness and tingling. And that's why we don't, when we see patients with piriformis hypertension or hypertonicity, we don't have numbness and tingling in all patients because of this variation, right? There are 6 possible. This is a there's a question. Is this an evidence that if there is nerve is beneath the piriformis that it cannot give symptoms? We can say, but we cannot say with surety because nerve can get entrapped somewhere else, right? We know that nerve has a tendency to get entrapped multiple sites, but yes, in 87% of patients, and this is a very, very old research, very established research. If you look at any article, recent article, they do quote this research because this is a very established, very highly cited article, and we call it like Beaton Anson classification. Okay, it's good to know that sciatic nerve not always passes through piriformis. Okay.
Okay. Thank you, sir. Rumi. Now we are going to see the 4 chief clinical signs which has been selected after the systemic review. They have been gone through a lot of researches and they have found that most of the researchers found out these 4 clinical signs in every case. So you should remember these 4 clinical signs which has been proven by the research. The first is the buttock pain, which is aggravated on sitting. The second is external tenderness near the greater sciatic nerves. Then the third is pain on any maneuver which will increase the muscle tension. And the final one is limitation of straight leg raising, which will vary according to the last images, because if there is muscle, what is the anatomical variation is there, on the basis of that we are going to get the assessment result on straight leg raising. So this is the one of the
This is one
research
of the
has been
system
done.
reviews, guys.
Yeah, one of the systemic review has been there. So where 105 research has been done. So out of that cases, more than 50% cases has been found that all these 3 symptoms, where it has been written in red. So out of 105 research paper, those over the cases of piriformis syndrome, they got these 3 symptoms. The symptoms were, the first symptoms were there, the buttock pain. The second symptoms was the radiation symptoms, and the third symptoms was the external tenderness. So most of the piriformis cases found these 3 symptoms. So it has been proven by the research. Next. So now we are going to see the etiology of piriformis syndrome. So what can cause the piriformis syndrome? So if is there any kind of trauma happens near your hip or buttock, if you history of fall down, anything which can cause injury to the sacroiliac joints or injury to your piriformis muscle, so it can cause the piriformis syndrome. Second is predisposing anatomical variants. The image which we have seen of the sciatic nerve and the piriformis. Now later on the myofascial trigger points. So after the chronic pain, we have seen many cases where piriformis syndrome is very chronic. Patient is telling you, I do have pain in my posterior buttock since 20 years, 10 years, 20, many, like since long days. So they got myofascial trigger points in their gluteus maximus, gluteus medius. So there are chances of myofascial trigger points has been occurred at the muscles. Later on, hypertrophy and spasm of piriformis muscle because of injury or because of all the muscles trigger points are just going to overuse the piriformis muscle. So there are the chances of spasm and hypertrophy of piriformis muscle can happen. And the secondary to laminectomy, as we have seen, L3 nerve root is going to it's going to supply to posterior hip. So laminectomy happens in lumbar region. It will also it can give you the piriformis syndrome like of symptoms where soft tissue involvement like abscesses, hematoma, myositis, bursitis, neoplasm, colorectal carcinoma, cancer, neuronema of sciatic nerve. This is also one of the type of cancer. Sacroiliac lipoma. So this can also give the pain, which can referred as the piriformis syndrome. Later on, intragluteal injections. Now many people are getting the injections of PRP and steroids. So that could also give you the pain in piriformis. Where femoral nailing, in femoral nailing, if any kind of surgery happen at femur joint, so that could cause gives the pain in piriformis. Where myositis ossificans of the piriformis muscle, any bony things happen after the fracture. So any calcium deposition formation kind of give you the piriformis muscle syndrome. And uh, clipal tendinous syndrome, which is the genetic disorder where there is a derangement happens in ligaments and the muscles. So what can happen? And that happens in your lower limb. So if there is a clipal tendinous syndrome is there, so there is the chances of hypertrophy of the muscles happen. And suppose this is happening in right leg, so there will be the heaviness will be occurred, and the patient can get the pain in piriformis. Now we are going to see the differential diagnosis of piriformis syndrome. So if you have the pain in the piriformis, so what could be the other diagnosis chances are there? So the first thing is dysfunction, lesions, and inflammation at sacroiliac joint. So sacroiliac joint plays the important role. As I have already explained that if you have any problems in sacroiliac joint, it gives the neurophysiological inhibition at the gluteus medius muscle, and it will give you the Trendelenburg sign. So the biomechanics of sacroiliac joint is also important. The second one is pseudoaneurysm in the inferior gluteal artery following gynecological surgery. If you see, inferior gluteal artery is the blood supply of the piriformis muscle. So if you find any kind of aneurysm, so it will give you the pain. So that could be the one of the reason for the piriformis syndrome. Later on, thrombosis of the iliac vein. The veins and artery supplies around the piriformis muscle, if they got thrombosed, so they will also going to give you the pain in your piriformis. Later on, painful vascular compression syndrome of sciatic nerve caused by the gluteal varicosity. So again, the blood supply where the iliac vein and the arteries can get compressed, so it can give the pain in the piriformis muscle. So as we see in herniated intervertebral disc as the lumbar part, the nerves as we see the Hilton's law. So nerve supplied from the lumbar area and it is supplied to the posterior hip. So this will give the referred pain to your posterior hip. Post laminectomy happen in syndrome. Post laminectomy syndrome, coccydynia. Same again in regarding the lumbar joint. Pseudoradicular uh, pseudoradicular S1 syndrome. Uh, so anything because the nerve supply of the piriformis muscle is S1 and S2. So if anything happens in S1 and S2 area, this will give you the piriformis muscle action muscles involvement. Later on, posterior facet syndrome, which will happen at L4, L5. Same the lumbar plexus gives the supply to the our posterior hip muscles. Later on, unrecognized pelvis fracture. Because of fracture, the pain might be related to your piriformis muscle. Lumbar osteochondrosis, where the degeneration happens in the spinal canal. The degeneration can be at your disc or at the spinal around the spinal canal, which can also show you the symptoms as like a piriformis syndrome. And the last one is undiagnosed renal stones. Many times patient shows the symptoms around your lower back or at the hip, but if you don't get better, there are the chances of there would be the renal stones in his kidney, his or her kidney. Now, what test we can do for special test for diagnosis of piriformis syndrome, but there is no such test as proven. This test is going to give us the exact clarity of piriformis syndrome, but there are the cluster kind of thing like Trendelenburg sign, Ober's test, Faber's test, Thomas test. It will help us to diagnose.
So there is no gold standard test for piriformis syndrome. It's a confused diagnosis. Okay.
Next, Dhruvi. So these are the specific tests for piriformis syndrome. If you see the date of published or date first described, so since 1934 till 2013, it has been shown many tests has been selected for the piriformis syndrome. So as I have already mentioned the pace test, so I will show you what is the pace test. Dhruvi, can you show the next slide? Yeah, so this is the pace test. The patient is sitting at the edge of the bed. Hip and knee is at 90-degree angle. So we saw that at 90-degree, abduction of the hip joint is the function of piriformis. So what he is doing, he is resisting the abduction movement at the hip joint. Suppose on the contraction or any stretching, if he gets the pain, so we can say there will be the piriformis muscle is in the picture. Next. Trendelenburg sign, as I have mentioned, gluteus medius is the muscle. The posterior part of gluteus medius muscle is going to help to maintain our both the hip joint at the same level, or iliacus or ASIS, PSIS at the same level. But if you see, if there is there any kind of sacroiliac dysfunction, so because of sacroiliac dysfunction, there will be the neurophysiological inhibition happens at the gluteus medius muscle, and because of that inhibition, muscles are not working properly and so the power goes down. So because of that, we found the Trendelenburg sign. Next. So Ober's test. This is the modified Ober's test. So patient is in sideline position. So we are just externally rotating the hip. The physio is by the side of the patient, and we flex the knee to the 20-degree. And after the external rotation and flexing the knee, we abduct and extend the hip and the palpate the iliac crest. And suddenly we lowers the leg. If thighs drops to the 10-degree and below the horizontal, so there are the chances of sacroiliac joint involvement is there, or any hip pathology is there. So for that, to rule out, we do the modified Ober's test. Next. Next is Thomas test. This test all we know. Patient is lying down and patient is trying to touch the knee to the chest, and the hip and knee is in flexion position. If patient the opposite hip gets lift from the ground or from the bed, so there are the chances of flexion contracture or SOS syndrome. So SOS major is involvement is there. So we can rule out the muscle by doing the Thomas test. Next. The Patrick test, which is also known as the Faber test. Faber stands for flexion, abduction, and external rotation. The patient is lying in supine position, where we are doing the flexion and abduction at the hip joint. So we are making the figure 4. figure 4 position at the knee joint, and we are going to stabilize the knee joint opposite AA side. So after doing the figure 4, we just give the external rotation to the hip joint. If it founds painful, then it gives the positive Patrick test. So it shows is there any involvement of SI joint is there or not.
Uh, we'll be sharing this presentation on YouTube, so you can very well relook at it. Most of our classes are.
Next.
Keep going, Dr. Prashant.
Yes, sir. Now refer them from the lumbar spine. As we have seen, we get the most of the blood supply, sorry, nerve supply is getting from the L3 nerve root. So if anything happens at the L3 nerve root, so we can get the referring pain at the posterior hip. Next. Now the major part is there, SI joint dysfunction. As I have already mentioned, if is there any pathology or any dysfunctions happen at a sacroiliac joint, it's going to hamper the muscles around the hip joint. So if you see the origin and insertion of the piriformis muscle, SI starts from the sacrum and it inserts on the greater trochanter of the femur. So there could be chances of hypermobility, trauma, degeneration, inflammatory, infection, or any ligament or stress. So that could be that could give the pain to the our piriformis muscle. One research has been done where ultrasonography ultrasonography has been done on the posterior. In that study, if pain is there, major cause of the pain has been found out as a sacrotuberous ligament. So if we see, if there is any dysfunction happens at SI joint, so there will be tension created at the sacrotuberous ligament. If we see what is the origin and insertion of the sacrotuberous ligament, it starts from here, it goes up like this. It starts from here, it goes up like this. So if any dysfunction happens, suppose the sacrum is going anterior, posterior, up slip, down slip, anything happens, so there will be tension will be created at sacrotuberous ligament, and it gives the pain to the patient. So it has been proven in research where the ultrasonographic study has been done.
Yeah. Another interesting point is that, I mean, when we talk about piriformis, I think Dr. Prashant mentioned that it's not just piriformis, it's inferior gemmelli. Okay. It's also sacrotuberous ligament. It's also obturator internus. So you're just, I mean, we tend to be biased towards piriformis and calling it a piriformis syndrome, but sometimes there are other pain generators too. And especially when you're examining them, you need to look at other structures as well. Oh, yeah. Dr. Prashant, you can keep going.
Yeah. So now pathology of the SI joint can be difficult to diagnose, but for that we need to do. There are many pathologies like tumor, neurological examination has to be done, or to rule out any pathologies, which includes radiographs, MRI scans, fluoroscopic guided injection to the SI joint, and the good manual therapist also can do the good assessment and can rule out the diseases related to SI joints. Next. So this is the image which gives the nerve supply related to anterior to the sacrum. So as we are talking about SI joint dysfunction, so these are the number of nerves which are present and on the anterior aspect of the sacrum. So if any dysfunction happens at the sacrum joint or in sacroiliac joint, so these muscle functions can get hampered. So we can see superior gluteal nerve, lumbosacral tongue, common fibular nerve, inferior gluteal nerve, sciatic nerve, pelvic parasympathetic nerves, posterior femoral cutaneous nerves, perforating cutaneous nerves, pudendal nerves, hypogastric nerves, anococcygeal nerves, flanking nerve, inferior hypogastric nerve, perforating cutaneous nerve. All these nerves are present on the anterior aspect of the sacrum. So if any kind of dysfunction happens, it can gives it can interrupt the function of all the muscles or all the soft tissues it is supplying to. For example, if you see the pudendal nerve, if pudendal nerve is involved, we get the bowel and bladder syndrome, or we can get the pelvic floor muscle symptoms. So the muscle which is supplied by one of these nerve can get the function of that muscles get hampered because of this sacroiliac dysfunction.
So the key thing, guys, piriformis is not exclusive to just buttock. If you look at all the nerves, I mean, it's almost supplies everything down the leg, right? I mean, if you look at the nerves, I mean, it supplies almost everything down the leg. So when you're treating piriformis syndrome, make sure you're keeping in mind that anything can get involved. And as Dr. Prashant mentioned, pudendal nerve, we see piriformis pain and we see pelvic floor inhibition, or we see symptoms of incontinence, symptoms of sexual dysfunction. So make sure that you're looking at this. A very interesting study. Thank you, Dr. Prashant.
Thank you, sir. Next. Now, coexistence of piriformis syndrome with SI dysfunction. So after there is a correlation of piriformis syndrome and SI dysfunctions, vice versa. So this has been published by the Yeoman in 1927, where he proved that there is a coincidence of SI disorder with the piriformis syndrome. There is no systematic or randomized controlled trials are currently available to conclusively prove this association. But if we see the changes, but while some case reports and some osteopathic expert opinion, these people are emphasizing on this coincidence. Still, we have lack of clear evidence. So further research has to be done for that. Next. So after all these slides, we are going to see a case study which I saw in my clinic, and I really want to share this experience. So before doing the gym masterclass or gym courses, this patient has to be, suppose this patient has to come to me, I used to go for ultrasound or TENS and all the traditional treatment. So I'll read the case history first. Later on, we'll discuss the assessment part. Later on, we'll discuss the treatment part of this. So the patient was 38 years old, research scientist in pharmaceutical corporation. So he had come with the pinpoint lumbar and buttock pain. So he had for that past 2 years, and the intensity of the pain has been increased since the last 2 months. When I saw him, 1.5 years ago. So previously, he consulted with orthopedician, primary care physician, and he did MRI. So where he found that L4 and L5 disc herniation. So since then he took the treatments, medication and all, but he didn't get any kind of significant change in his symptoms. So the orthopedician sent him to the gastroenterologist because he was saying I get sometimes stomach upset and all. So he went to the gastrologist. So he did some ultrasonography, ultrasound, abdominal ultrasound sonography. So he found that there is no abnormality in that sonography. So he gave him like multivitamin tablets, like vitamin D3 and some multivitamin tablets. So later on, he went to the number of physiotherapists. So before coming to me, he had been to the 8 physiotherapists. So he has gone through the ultrasound, TENS, massage, and myofascial release, matrix therapy. Also, he has gone through and few exercises. But post that, he found better for a while, but all the symptoms came back again. So after the treatment, he used to feel better, but next day he used to feel the pain again in his hip. So there hasn't been much improvement in the symptoms. Later on, we did the assessment. Next. So we found clinical findings are there. We found that he has the right hip pain. So flexion was 120 degree. So extension was near 20 degree, which was painful at the end range of motion, and external rotation were restricted, and internal rotation was 30 degree. So this was the range of motion. And after MMT, we found that right PGM, posterior gluteus medius muscles power was 3 -3 on 5, and external rotation strength was -3 on 5. Sorry, 3 on 5. Right hip external rotation strength was 3 plus on 5, where right gluteus max was 3 plus on 5, and supine to sit test was short to long. I will explain later on what is supine to sit test. And on palpation, we have seen sacral base was deep and infrolateral angle was prominent, where sacrotuberous ligament was tender and painful on palpation, and he had closing dysfunction at L5S1 and he has restriction in extension, side bending, and rotation in his lumbar joint, where multifidus activation was poor. So, sir, should I explain this supine to sit and TJ, sir?
Yeah. Supine to sit is nothing but, so what you're trying to do is your patient is in supine lying, and you check the medial malleoli on either side and compare the leg length. So in this case, the leg was shorter on the right. When you ask the patient to come in long sitting, you check again, and the affected side becomes longer. So we conclude that the patient has a posteriorly rotated pelvis on the right side, on the affected side in this case. And then we did like static palpation of sacral base, which was found to be deep. I mean, I think Dr. Prashant was talking about
Yes.
sacrotuberous ligament and ultrasound studies. He found sacrotuberous ligament to be tender to palpation. I think there are a lot of studies which talks about piriformis and sacrotuberous ligament, like ultrasound studies where they were testing for piriformis syndrome, but they found like the tissue consistency of sacrotuberous ligament was affected. So with palpation, he found very similar findings, which research, research, you find the same thing. So, yeah.
Now we'll discuss this case. Next slide. So the diagnosis of this case was unilateral flexure. So now we are going to see what is the unilateral sacral flexure. If we see the images, while doing the flexion movement, the pelvis is going anteriorly, and while doing the extension movement, the pelvis is going posteriorly. So are you able to see this? So consider this sacrum is as the person in front of me is standing, root sacrum. So this is the part of sacrum, and this is the ilium. So if we see, this is the sacral base, and this is the infrolateral angle of the sacrum bone. So which is the prominent part, or which we can palpate. So if we see the last case, where we saw that patient was having pain on the right side. So this is the right side of the sacrum. This is the left side of the sacrum. The patient is facing me. So this is the posterior view of the sacrum. So where what found out the PSIS, after finding out the PSIS, we find out the sacral base. So this is the sacral base, and after the find out the sacral base by making a triangle, we found out the infrolateral angle of the sacrum. So in this case, what happened on palpation, this part was deep as compared to the left side. So this part was deep, and this part was tender and painful on palpation. So if you see the case, the right sacral base is deep in the clinical findings, and the right inferior lateral angle is tender and painful. So suppose this is the ilium, this is the sacrum, this is sacroiliac joint. When sacrum is going into flexion, so this is the flexion, this is the extension. I am talking about the right side. Just see on the right side. So this is the flexion, this is the extension. So this is the ilium. So if this part is going into flexion, right part is going into flexion, it's going anteriorly and deep, and this part is coming up and prominent, where as compared to the sacrum, the ilium is moving posteriorly. So this is the ilium. If it's going anteriorly, relatively it's going posteriorly. So the finding of that test was supine to sit. The when the patient uh, just a minute. When Rumi, can you open the clinical finding? Yeah. So if you
Can you
see the
talk a
clinical
little
finding,
bit about? Can you talk a little bit about closing dysfunction L5S1?
yeah,
I mean,
yes. So what is the closing dysfunction? Just a minute. Closing dysfunction at L5S1. So if you look at the movement in lumbar joint, there is movement happens like flexion, extension, and side flexion. So when we do the flexion, at that time there is an opening of facets happen, and then the anterior joint is moving on the inferior joint. The anterior vertebra is moving on the inferior vertebra, and while extension the clearly. So what happens in restriction closing dysfunction, when we are doing the extension on L5 and S1, it is unable to close. So patients are finding difficulty in closing. Means while suppose this is the L5, this is the S1 inferior facet, this is the superior facet, this is inferior facet. So while doing the extension, it should go like down. So it should get closed. But suppose it is unable to close, patient found difficulty in all the restriction in all the movements. So this is known as the closing dysfunction at L5 S1. Am I clear to everyone?
yeah, you're fine. You're fine. You're fine. So basically, what is happening is, I mean, L5 is not able to go. We call it down and back. Not able to glide. I'm just gonna. So if I have to just 1 second, guys, I'll show this. If this is L4, L5, this is S1. When you do extension, extension, right side bending and right rotation, this should glide down like this. And this motion is restricted. The closing dysfunction is on only usually one side, so it's right L5S1. Okay. And this is the secondary dysfunction to the primary dysfunction. Can you guys see the video? Am I visible to you guys? Okay, let me actually just 1 second, guys. Okay, so this is L5. This is S1. When you extend, this goes down like this. This goes down like this, right? And when I extend, side bend, rotate, this should go like this, right? Okay, this should go like this. Whenever you have this closing dysfunction, this down and back motion with extension, right side bending, right rotation is missing. Okay. Yeah. So this extension, side bending, right rotation is missing, and this is L5 is not smoothly gliding down on S1. Okay, and that is what this closing dysfunction is. Yeah, I hope it makes sense. Okay. Over to you, Dr. Prashant. I hope this answers it. Yeah.
So just now I have explained you the clinical findings when I said, suppose this is the ilium, this is the sacroiliac joint. So right sacral base is deep and the inferolateral angle is prominent. So this movement is happening on right side. This is the posterior right side. So relatively, it is going posteriorly. The ilium is going posteriorly relatively to the sacral movement. So if you see the supine to sit is short to long, so the interpretation of short to long is posterior innominate rotation. So how the posterior innominate rotation happening? Sacrum base is going deep, where inferolateral angle is getting tender, and relatively innominate going in posterior direction. So that is the interpretation of short to long. So this is known as the unilateral flexion. So if you see the symptoms of the unilateral flexion, the patients might be having the back pain and buttock pain with or without radiation. But most of the time, patient says there is a pinpoint of pain in your posterior hip. So earlier, I used to see this kind of patient. I used to give ultrasound only, but he had been to the many physios before me. So I did the clinical findings, or I did the assessment, and I found that clinical findings. Later on, I did the manual therapy, METs, and few exercise prescriptions. So he got better in 2 sessions only. So where he did 3 to 4 months physiotherapy earlier to me, now he just did to follow up, and by doing the MET and manipulations, we got him pain free. So now we are going to focus on the next part would be the treatment part. So what would be the treatment for this unilateral flexion? So treatment would be like we'll do the lumbopelvic stabilizations, the exercises like bridges, clamps, pretzels, prone hip extension, and SLR. We'll explain in detail next. Now we are going to see the treatment protocol for the unilateral sacral flexion. Rumi, can you go for the next slide? So we are going to see manipulation techniques, MET, and exercises. So we have seen the symptoms were like, or the clinical findings were, posterior innominate rotation would be there, and the sacrum is one side of sacrum is in the flexion position. So to we are going for first MET. So the position of the patient is in prone line. Where the leg is in the 15-degree abduction and internally rotated, and the physiotherapist would be the from the behind of the patient. My right hand hypothenar would be on the eye of the patient, and my left hand is just reinforcing my right hand, and my position is like my both the elbow are straight, but while inhalation I'm just trying to give the force towards in anterior superior direction to the ila. So I'm trying to give the these things I'm trying to do. The it has been done in this position, so I'm trying to do it. This is in posterior. I'm trying to do this by doing the MET, by doing the muscle energy technique. While inhaling I'm just going to apply the force, and I'm going to maintain that force while exhalation also. So I'm doing the MET for the unilateral sacral flexion. The dosage of the MET would be 10 into 6 seconds with the medium intensity force. So after doing the MET, we can recheck the position and we can do the reassessment. So are we doing on the, are we able to correct it or not? Or if we are not going to correct it, or if we are not finding the result, we can repeat it 3 times. So this is the MET techniques for the unilateral sacral flexion, where legs in 15-degree abduction and internal rotation. So I'm just applying the force on the ila in anterior superior direction. Next. Dhruvi, can you play this video?
So this is a technique to gap posterior aspect of your SI joint. Yeah, this technique can also be used for L5S1. So this is a great technique because it is gapping L5S1, which we know is sitting in closing dysfunction and correcting posterior nominate dysfunction as well as unilateral sacral flexion. So 1 and 3.
So this is the manipulation technique for that. The first was the MET technique. Now we are going to see the exercise prescription. As we have seen, the external rotators were weak. That was the 3 on 5. So this is for the external rotator strengthening. The patient is in side lying, so the hip knee at 90 degree at the edge of the bed. Now patient is the right leg is outside the bed, so patient will do the internal and external rotation at the hip. So this is the known as the pretzel exercise, which will help us to increase the strength of the external rotator of the hip. Next. So as we have seen, the multifidus activation was poor. For multifidus training, we are going for stagger stance weight shift. I'll show you how to do this. And the prone hip extension, the patient is lying in prone position. So that is the short arc hip extension, where we have bend the knee at 90 degree. We will do the extension at the hip joint. I'll show you the stagger stance weight shift. So I'm standing in lunge position, sorry, in stagger stance position, and my both the hands are just lateral to the transverse process of the lumbar spine on the multifidus. I am just shifting the weight on my right leg. My right leg is ahead and left is behind. I am just shifting the weight on right leg and coming back to the normal position. So it will help me to activate my multifidus muscle. So we can do on left side also. So left side will be ahead. So we'll shift on left leg. We'll come back to the position. We'll shift on left leg. So you can feel the contraction at multifidus muscle if you do it practically. Next, Brumi. Next muscle is clamps with progression. This muscle is for the gluteus medius activation. We have seen the in assessment in clinical presentation where the gluteus medius was weak. So these are the progression. The right one has been written. That is the first the hip and knee at in bending position. So we are just going to do the external rotation at the hip joint. That is the first step. We can progress it with the TheraBand. Later on, we can progress with the lifting of the leg. So that are the three progressions of the clamps has been there. So that will help us to increase the strength of the gluteus medius muscle. Next. So this is a monster walk exercise where so this is a little bit in squat position. So TheraBand is tied around your mid thigh and you just do the side walking position. So it will help you.
Basically, it's a gluteus medius activation in functional position.
Yeah. So extensor part of your hip, gluteus medius activation. Brumi next. So for the posterior hip chain,
you can do the master walks without the band. The idea is we are trying to work on everything we found to be inhibited. We found the posterior gluteus medius strength to be 3 on 5 or 3 plus on 5. We found hip external rotators to be weak. We found gluteus maximus to be weak. We found multifidus to be not activating well. So we're just trying to, Dr. Prashant is just showing us various exercise ideas to work on the things which he found to be weak. And that's what we do, right? If we find something weak, we want to train them after we fix the positional faults. Okay, and hopefully that piriformis will just calm down. Yeah.
Next exercise was bridging and its progression for posterior hip chain. So we found that gluteus was weak and hamstring. So we were focusing on hamstring plus gluteus. So this the number one, that is the basic gluteus bridging we did. That would be the progression with the gluteus medius activation when we tie the TheraBand. Next slide. That would be the that would be the third progression. We are keeping both the heel on the stool, or we can put on the step, and we do the bridging with both the legs. And after that, if you want to progress it, we can do the SLR on one side, and other side will be on the stool or step. We can do the bridging. So these are the four progressions of bridging exercises. Next. Yeah, these are the references from where we took the slides and all the information. Thank you guys for being patient. And thank you, PJ sir and Steve sir, for this opportunity.
Thank
And
you, Dr. Prashant. I mean, I think we're going to stick
and
around.
thank you. Yes, yes. If you have any doubts, you can ask in chat box.
Yeah, do you mind going back to the previous slide, to the bridging? I think there are various forms of bridging exercises you can do. You can do it with or without band. You can do it on the chair. You can do with a single leg. You can do with the SLR. You can do like a wide variety. This lecture will be available on YouTube so that you can go back and relook at the slides. I think the idea is that all of us can treat better than we treat. I mean, and you can follow us on various social media channels or social media platforms rather. Yeah. Thank you, Dr. Prashant, for the great lecture.
Thank you, sir, for this opportunity. Thank you, Dhrume, for coordinating.
You guys can follow us on Instagram or and Facebook and YouTube. This lecture will be there on YouTube. Please tell me the difference between anterior pelvic. Can you go back to anterior and posterior pelvic tilt slide one more time? Yeah. So if you look at this, anterior pelvic tilt includes where ASIS is going down. I think Dr. Prashant was talking about two horizontal lines, and you can see that and ASIS is going down, causing close kinematic chain flexion. Exactly opposite is happening in posterior pelvic tilt. You're getting that kind of relative hip extension with posterior pelvic tilt. Yeah. So this is the interesting thing. So if you're trying to differentiate between obturator internus and gemelli from piriformis, with physical exam, it's almost impossible. And that's why, because piriformis being the biggest muscle, we tend to say it's a piriformis syndrome. But a lot of people who do ultrasound guided dry needling or ultrasonic studies, they can find the differentiation between piriformis and obturator internus. I think there are people in the US who teach courses where they teach dry needling, ultrasound guided dry needling, and they can really differentiate between obturator internus, inferior gemelli, and piriformis. Physical examination, I think, is not enough. Yeah. But the point is the point we were trying to make is it's just not the one muscle. If it was just one muscle, I know that's a muscle we've studied a lot research-wise, but it's just not one muscle. It's just three external rotators trying to become hypertonic, and you have to find why they're hypertonic. I think Dr. Prashant discussed that in greater detail. Yeah. Any more questions, guys? Okay, that's a good question. I mean, yes, I mean, ideally both should be positive. If you contract, it should be positive. And if you look at the tests, I think, Dhrumi, can you share that slide where we were talking about all the special tests? So either you can contract the muscle or you can stretch it. You can do Superman's exercise if you're finding glute max weakness. Yes. And Superman's also target the multifidus. You can definitely, with this specific patient, yes, you can do a Superman's exercise. So I think go to the next slide. Next slide. Slide after this. Yes. So if you look at this, I mean, no, previous slide. Sorry, previous slide. Yeah. If you look at this slide, I mean, you can see that some of these movements are nothing but you're just trying to stretch the muscle. Fair test. Maintaining the hip inflection, abduction, and internal rotation. This is a piriformis stretch technically. And then you see this active piriformis. This is a resisted test. Resisted piriformis test. So either you can activate the muscle or stretch the muscle, but that's not the point. The point is why, which I think Dr. Prashant explained it, why the piriformis is becoming angry. Other sacral dysfunctions can cause piriformis syndrome or can be related to piriformis syndrome, but unilateral sacral, if you look at the osteopathic literature or some of the case studies, unilateral sacral flexion has more propensity towards getting this kind of syndrome. But other sacral dysfunctions can sometimes give you piriformis syndrome. Yeah. And I think enough literature out there, starting from human to like recent research, piriformis syndrome and SI dysfunctions go hand in hand. So the idea is not to treat piriformis syndrome and understand the anatomical variations of sciatic nerve has a strong association with it. Yeah. I mean, I think it's sometimes very good to look at the literature because it opens your eyes towards other things. Okay. You can pick up any osteopathic book. Can you explain your question? J stroke by IASTM. I'm not a fan of IASTM. Research on IASTM is very limited, if that's what you're asking. I mean, any more questions, guys? Release the PSIs. Yeah, you can try to by ASTM. Yes, you can, but you have to fix the underlying cause. Yes, you can do all the soft tissue work, all the massage. If you look at the case study Dr. Prashant presented, he was talking that the patient had massage done, all the passive modalities done. ISTM is nothing but massage by a instrument, right? Yeah, and the evidence on ISTM is so poor. I know Sharmi mentions that even long can give you symptoms. What are your views on it? Yes, weak hip external rotators can give you symptoms. Long means weak, right? So weak hip external rotation can give you can give you symptoms. Sometimes it actually depends on the Craig's angle. We always talk about how Craig's angle make a determination the strength in your hip internal external rotators. So I would also look at strength in the hip external rotators. So when you talk about long piriformis, we talk about hip external rotation strength being less, okay, which I think Dr. Prashant spoke about. His patient had only 3 on 5, right? Sometimes targeting the piriformis also, yeah, I mean, absolutely. If you're targeting piriformis, you're definitely affecting sacral mechanics, right? Yeah, so it can affect, I mean, can sometimes improve the activation in gluteus medius. And if you improve activation in gluteus medius, it will change the loading pattern, and can improve medial knee pain for sure. Right? If you've attended our courses first, you know what I'm talking about. I think next weekend we're going to be doing another free lecture. We're going to be talking about complex regional pain syndrome. Okay, we're talking about complex regional pain syndrome. We're going to talk about role of manual therapy. Some latest systemic reviews have been published on it. Journal of Orthopedic, or JOSPT, Journal of Orthopedic Sports and Manual Therapy, has published some very recent research on it. So